Welcome to meeting number 131 of the House of Commons Standing Committee on the Status of Women. Before we begin, I'd like to ask all in-person participants to read the guidelines written on the updated cards on the table. These measures are in place to help prevent audio and feedback incidences and to protect the health and safety of all participants, including the interpreters. You will also notice a QR code on the card which links to a short awareness video. To all members, again, please wait until I recognize you by name prior to speaking, and a reminder that all comments should be addressed through that of the chair. Merci à tous pour votre coopération.
Thank you all for your cooperation.
On Tuesday, June 4th, 2024, and Wednesday, September 25th, 2024, the committee will resume its study of breast cancer screening for women aged 40. At this point, I would like to welcome all of our witnesses, all appearing by video conference this morning. As an individual, Dr. Nadine Caron, professor. From Ontario Health, we have Alethea Kawashosh, Director, Indigenous Cancer Care Unit and Indigenous Health Equity and Coordination. Dr. Amanda Shepard, Senior Scientist. From the Olive Branch of Hope Cancer Support Services, we have Juliette Danielle, Professor. At this point, we will begin with our opening remarks. Each of you have up to 5 minutes. Dr. Caron, you have the floor for the first 5 minutes. Thank you.
Thank you, Miigwech. Merci. I'm joining you today from the traditional and ancestral territory of the Lheidli T'enneh peoples, Prince George, British Columbia. I am a cancer surgeon and professor at UBC. I join you today as an Indigenous woman, daughter, mother, sister, auntie, cousin, a member of the Sagamok Anishinaabe First Nation. I work in the field of breast cancer with many hats, and I strongly recommend to move or return the breast cancer screening guidelines to commence at the age of 40 as opposed to the current age of 50. The current guidelines in BC state that screening mammography is available to women in their 40s and recommend that women at average risk start screening mammograms at the age of 50. There is a distinct difference between a service being available and a service being recommended. These guidelines, current and previous, have never, to my knowledge...
We have a question from the floor from one of our members.
I'm so sorry. Can you turn up the volume? Because I can't use my earphone because there's an echo.
Certainly.
On the floor? Thanks.
At this point, we'll attempt to turn up the volume, and with the consent of all of you, I'm going to take these television screens off so that the sound from the projectors helps people hear a little bit better. Is that fine? Okay, so we'll turn it up and we'll start this process. In the meantime, I apologize for having to interrupt you, and you can...
That's okay.
...off, and I'll just be mindful of the time.
Okay, great. So just to recap a bit, there's a difference between a service being available and a service being recommended. And these guidelines, current and previous, have never, to my knowledge, taken Indigenous data or perspectives into consideration. In recent research with the First Nations Health Authority and the BC Cancer Agency, we have found that when looking at First Nations women in British Columbia compared to all other women in British Columbia, First Nations were diagnosed at a later stage of breast cancer. First Nations women had a lower breast cancer survival rate. Screening mammography rates were lower for First Nations women, and this was very evident in the 40 to 49-year-old age group. And attachment to a primary care provider is lower for First Nations women, which may explain the lower mammogram rates in this age group, as discuss with your healthcare provider is suggested when women consider it at this 40 to 49-year-old age group. The guidelines do indeed state to start at the age of 40 if individuals are considered at a higher risk. So currently, the age recommendation changes based on risk factors. This is vital. These definitions of risk have limitations from an Indigenous context and therefore do not seem to take Indigenous realities and challenges into consideration. For example, high-risk women includes those that are carriers of a pathogenic gene variant that significantly increases their risk of breast cancers. Fancy words for saying DNA or genetic bases, such as BRCA1, BRCA2, and a list of others. There are concerns regarding inequitable access to hereditary cancer testing and research And while it has not been proven, I suspect it is similar to other documented disparities in access to genetic and genomic testing and care for Indigenous people. These inequities in this healthcare field may limit access to screening mammography based on the current guidelines. If you or your family don't get referred or tested for these genetic variants, then how do you know these recommendations to start at the age of 40 even apply to you? The other risk factor that current guidelines use to recommend starting at the age of 40 rather than 50 is family history. Women with a family history of breast cancer are considered at higher risk based on specifics: number of relatives with cancer, if they're first degree, the age they were diagnosed. These guidelines, as they stand, make mammography already recommended at the age of 40 for those with a family history that match the criteria. This is something that I just don't think we look at. What if you don't know your family history? What about factors that potentially changed your family history? What if that in itself is a barrier? What if your family history or potential family history increases your risk of developing breast cancer, but not knowing it decreases your access to the screening that can save your life? Consider Indigenous people in Canada. The legacy of the Indian residential school systems includes women like my mom who were disconnected from their family, their culture, their community, and may have led them to not returning or staying in their community and losing their knowledge of their family history. Those children who never lived to leave residential school, caveat, I grew up in Kamloops, BC, and the number 215 is ingrained in my soul. These children didn't grow up to be a sister with breast cancer or an aunt or a daughter with breast cancer. The 60 Scoop left individuals completely cut from their family, with many never knowing that they had a family history that would match the criteria to get a screening mammogram when they were 40. Forced relocation of Indigenous communities separated families, including the stories so that they could learn their family history. The egregious differences in life expectancies and statistics between Indigenous peoples in Canada and the rest of Canada includes decreased or increased deaths in childhood and young adulthood, from infant mortality rates to teenage suicide, trauma, and otherwise. Our family members may never have grown up. Our family members may never have grown up to be a sister with breast cancer, an aunt with breast cancer. So many of my patients have been robbed of their family history, not knowing it, or our loved ones never growing up to be adults. Yet it determines access to services to detect a common cancer that is treatable if detected early. Indigenous women should be recommended to start screening mammograms at the age of 40, given that criteria to obtain it at the age of 40 is based on risk assessment that is a barrier in itself. Screening mammograms change lives. I think we should remove limitations to access it. Chi Miigwech.
Thank you very much for your testimony. At this point, I would like to welcome Ms. Kiwayash with Dr. Shepherd. You have the floor for 5 minutes. You are on mute, Ms. Kiwayash.
Sorry about that. Good morning. Thank you. Good morning. My name is Alethea Kiwayash, Director, Indigenous Cancer Care Unit and Indigenous Health Equity and Coordination Unit for Ontario Health. Joining me today is Amanda Shepherd, Senior Scientist, Indigenous Cancer Care Unit. Thank you for the opportunity to appear before the committee. Ontario Health is an agency of the Government of Ontario with the mandate to integrate and transform Ontario Health's care system. Ontario Health connects and coordinates the health system to make transitions and care easier for Ontarians with a focus on driving value and ensuring equitable access to high-quality care when and where it is needed. Indigenous people are the original inhabitants of Canada. Indigenous people are not a cultural group to Canada, but are a distinct constitutionally recognized people with Aboriginal treaty rights. There are over 400,000 Indigenous people in Ontario. These estimates undercount the true number of First Nations, Inuit, and Métis people in Ontario. Retrospective cohorts of females for First Nations and other Ontarians were examined to assess breast cancer incidence, mortality, and survival. First Nation females had significantly lower incidence and mortality. However, once diagnosed with breast cancer, First Nation females were significantly more likely to die compared to other Ontarians. In a matched cohort design comparing First Nations to non-First Nation women diagnosed with breast cancer in Ontario, survival was more than 3 times poorer for First Nation women diagnosed at stage 1 than for non-First Nation women. Furthermore, the risk of death after a stage 1 breast cancer diagnosis was about 5 times higher among First Nation women with a comorbidity other than diabetes and was more than 5 times greater for women with diabetes than for those without a comorbidity. Therefore, having a pre-existing comorbidity was the most important factor in explaining the observed survival disparity among First Nations women. Improving care at breast cancer screening could increase their survival after early-stage breast cancer diagnosis. There are very few studies that have examined breast screening uptake in Inuit and Métis. The Ontario Breast Cancer Screening Program is a province-wide screening program that aims to reduce breast cancer deaths through regular screening. The program offers screening to 3 different groups of people who qualify for breast cancer screening. People's age 50 to 74 at average risk. OBSP recently expanded to people age 40 to 49 and people age 30 to 69 at high risk. Indigenous adults are often under or never screened when it comes to cancer screening. There are many reasons for this, including intergenerational trauma, social determinants of health, and specific to health and cancer care, stereotypes and prejudice, communication barriers, lack of translation, lack of trust for the medical system, no family physicians, poor coordination of care, and jurisdictional issues. There is no terminology for cancer in most First Nation languages. In some First Nation communities, cancer is a taboo subject surrounded in secrecy and fear because historically cancer was rare among First Nation people. Historical and cultural contexts have contributed to unique views of and a generally pessimistic attitude toward cancer. When asked what they thought of cancer, the response was usually, it's a death sentence. These views may impact the receptiveness to cancer education and prevention and delivery of care. Traditional spirituality, which is important to many Indigenous people, may contribute to beliefs about cancer. Ontario Health aims to improve cancer care for First Nations, Inuit, Métis, and urban Indigenous people in Ontario. The Indigenous Cancer Care Unit strives to reduce inequities in care and access to cancer services to ultimately improve cancer outcomes. We do this by collaborating with regional, provincial, and national Indigenous and non-Indigenous partners and organizations to develop and implement Indigenous cancer strategies. Working together with the regional cancer programs and Indigenous partners, the ICCU ensures that proposed programs and strategies are relevant and have the potential to be highly effective at individual, family, and community levels through the development of regional Indigenous cancer plans. One of the strategic priorities within the Indigenous cancer strategy is cancer screening. The main objectives are to improve access and participation in cancer screening, improve coordination and integration of cancer screening services, and support specific initiatives to improve organized cancer screening programs. I'd like to say I also share and appreciate the comments of the speaker prior to me. Thank you for your time, and I look forward to any questions that may come forward. Miigwech.
Thank you very much. Lastly, you have the floor for up to 5 minutes.
Okay. Good morning, bonjour. First, I'd like to thank the Standing Committee on the Status of Women for inviting me to appear as a witness for its study of breast cancer screening for women aged 40 to 49. I am a professor and cancer biologist at McMaster University, a 15-year breast cancer survivor myself, and a member of the research subcommittee of the Olive Branch of Hope Cancer Support Services, or TOBO. I have been partnering with TOBO for the past decade to organize and host Think Beyond Love Pink breast cancer awareness and education workshops and symposia, specifically for Black and other racialized women who consider a breast cancer diagnosis to be a curse or a stigma. TOBO's mission is to tackle this stigma head-on, since knowledge is power, and we know that an early diagnosis of breast cancer correlates with good survival outcomes. Due to advancements in early detection, screening programs, and treatment options, breast cancer mortality rates have actually declined almost 50% in the past 4 decades, from 42 deaths to 22 deaths per 100,000 people. However, epidemiological data continues to describe cancer disparities among racialized Canadian females, which contributes to overt inequities in lived experience during the cancer care continuum and in survival outcomes. I just celebrated my 25th anniversary as a professor at McMaster, and for the first decade of my career, my team was focused on characterizing a novel transcription factor that I discovered and named Kaizo. As it turns out, Kaizo is implicated in many aggressive human cancers, including breast, prostate, lung, and pancreatic. But more importantly, we recently reported that Kaizo levels correlate with disparities in breast and prostate cancer outcomes in Black men and women, respectively. In 2008, I heard for the first time about the aggressive triple-negative breast cancer, or TNBC subtype, that was disproportionately affecting young premenopausal African American and West African women compared to white women. Currently, most studies and data about breast cancer and triple-negative breast cancer in Black women are based on U.S. data. As a Black Caribbean woman, I was intrigued by these studies, and in 2011, during my second research leave, I began studying TNBC in Caribbean and West African women. Since there was no published literature about triple-negative breast cancer in the Caribbean or Canada, and Canadian hospitals were not collecting disaggregated demographic data for cancer or any disease. My research team is specifically interested in determining if there's an ancestral genetic predisposition or susceptibility to triple-negative breast cancer in women of African ancestry. Since the TNBC prevalence in West Africa ranges from 40 to 70% in Ghana and Nigeria, 20 to 22% in the Caribbean and the US, but only 10% among white women in the USA, suggesting that this could be something inherited from our ancestral slaves from the transatlantic slave trade. What is most concerning, however, about breast cancer in Black women is that despite having a lower incidence of breast cancer compared to white women, Black women have the highest mortality rate from breast cancer, and Black women under age 50 have twice the mortality rate compared to white women. This is possibly due to the fact that there are no targeted therapies for triple-negative breast cancer, which is most prevalent in Black women. In contrast, white women tend to be diagnosed with estrogen receptor positive breast tumors, which are effectively treated with the drug tamoxifen. So because there are no targeted or specific therapies or drugs to treat triple-negative breast cancer, any woman, be they Indigenous, Black, Latina, Asian, or any other ethnicity, any woman diagnosed with triple-negative breast cancer has a poor prognosis because they can only be treated with radiation therapy, which targets the breast itself, and standard chemotherapy that affects all proliferating cells in the body, such as our hair and intestinal cells. Earlier this month, we were excited to read a published article by Wilkinson and colleagues from the University of Ottawa, which was the first study of breast cancer incidence and mortality by age, stage, molecular subtypes, race, and ethnicity in Canada. They reported that compared to white women, other Canadian women had an earlier peak age of breast cancer diagnoses, and more cases were diagnosed under the age of 40. They also reported that Black women have statistically more breast cancer diagnoses at stages 3 and 4 combined, 26% versus 17% for white women. Notably, the proportion of aggressive triple-negative breast cancers among Canadian Black women was twice that of white women, 20% versus 9.5%, a statistic that is very similar to the US data comparing African American women to white American women. Wilkinson and colleagues concluded that initiation of breast cancer screening at age 50 would likely disadvantage women who have more breast cancers diagnosed before the age of 40, which may partially explain the higher proportions of advanced breast cancer diagnoses in many younger racialized women than white women. One size does not fit all, and on behalf of the Olive Branch of Hope, Black Canadian, and other racialized women, I urge the Canadian Task Force on Breast Cancer Screening and the Standing Committee on the Status of Women to consider revising the recommendations to account for populations that are at risk for early onset and aggressive breast cancer subtypes. And I would also like to say that I concur and agree with Dr. Caron, who has pointed out that the criteria for being classified as high risk does not consider the lived experience of marginalized communities in Canada. Thank you.
Excellent. Thank you all for your testimony this morning. At this point, that does conclude all opening remarks. I would like to move to our first round of questions. We will begin this morning with Michelle Ferrari. You have the floor for 6 minutes.
Thanks, Chair, and thank you to our witnesses today for attending the status of women as we continue our study on breast cancer and the recommendations by the National Task Force. Your testimony is obviously very important in this study. And you've brought up some very good points. In the second half of today's meeting, we're actually going to have the chair of the task force here. And I think it would be very useful to hear from you guys what you would like to ask that chair. I know you've given your recommendations, but to Dr. Caron, you said something that really jumped off the page to me. And in this world of Parliament, one word can make a world of difference. And you said there is a very big difference between available versus recommended. And I'm going to give an opportunity, if I can, to both you, Dr. Caron, and Professor Daniel, to put on the record what you would like to ask the task force and the chair, because we've heard a significant amount of testimony throughout this study, breast cancer survivors, doctors who weren't consulted. They're not happy with the recommendations of this task force, and they'd like to see it changed. So what would you like to ask her? I'll start with you, Dr. Caron.
Thank you. I really appreciate you acknowledging what I said in terms of words. Is so much there. The power of words to heal, and the power of words to harm, the power of words to clarify, and the power of words to confuse. I have so many patients over the years as a female breast cancer surgeon who have seen hundreds of women with breast cancer and or along that pathway who were confused that they were simply not recommended to have a mammogram. They were
Like what the average age of those women would have been?
For the most part, unfortunately, I'd like to say that it was women in the 40 to 49-year-old age group that were not recommended to have it because it was simply something they could consider, and it could be made available to them should they want to pursue that after a discussion with their primary care provider. Unfortunately, in British Columbia and across the country, when it comes to accessing and discussing this with a primary care provider, that age group also includes any woman who should be considering a screening mammogram because either the lack of understanding of what a screening mammogram does and what it's for, the fear of, when I'm speaking from the Indigenous perspective of my Indigenous patients and my family members of pursuing care in the healthcare system, the lack of cultural safety, the lack of access to a healthcare provider to talk to about this, all of that becomes something that then creeps into the 50 plus age group, where it is strongly recommended in the guidelines to start screening mammography. But most of my patients don't search the website to find out what BC Cancer is recommending or what is being recommended. So they don't have the access to a primary care provider that says, hey, you're turning 50. I strongly recommend you have a screening mammogram. But when it comes...
I don't have much time. Sorry, go ahead and finish up.
Yeah, but when it comes to women in their 40s, they're not recommended to have it actively in most cases. And so it's upon them to find a primary care provider or to search for this information and to have the courage to enter the healthcare system when it's something that is available to them but not strongly recommended.
Brought up a very interesting point, right? Access to a primary caregiver, and we know that that is probably one of, not if the largest issues across this country. We still have a massive healthcare crisis in this country. So I guess if I could move to Professor Daniel, here's the question. Why would a chair of a national task force have different recommendations than every province and every witness we've heard, it doesn't add up. Like, it doesn't seem to make any sense to me. And I think a lot of my members, a lot of the members on this committee feel the same way. Can you give your 2 cents on what you're seeing or what you think here or what you'd like to ask her?
So thank you. So I guess a couple questions would be, I forgot to look up the composition of the task force, but I think that would be one question. What was the composition of the task force? Were there any cancer survivors or caregivers? Was there diversity representing the multicultural, multi-ethnic nature of Canada? And how open-minded were they to that, to the task force itself and the comments or consultations that they conducted? Because as you noted, many people have complained or pointed out that they were not consulted. Another question I would have for the chair is whether they are aware of the American Association for Cancer Research, or AACR's, not so recent, 3-4 years ago, they have added racism as a social determinant of health and a risk factor for cancer development. Consequently, that means marginalized communities, as here in Canada, that would specifically pertain to Black and Indigenous communities that experience significant levels of racism. What it means is that racism has resulted in epigenetic changes of our DNA. So those aren't mutations, they're just marks that are added to our DNA that are passed on through intergenerational the trauma from that racism. So these epigenetic marks could have been from, for example, in Dr. Caron's case, her ancestors and how they were treated in residential schools. In my case, how my ancestors as slaves were treated as slaves. And I have inherited those epigenetic marks without even knowing that that was happening.
Thank you very much for that.
I would also like to ask the chair, what would they say to someone like me who was diagnosed at the age of 45? The reason I found the lump is because my mother passed away when I was 22 of ovarian cancer, and that is what inspired me to become a cancer researcher. So I was very aware of what I needed to look for, what I needed to do. My physician and I were incredibly careful, my family doctor, I should say. We were incredibly diligent with assessing my health on an annual basis. I had my annual physical in October of 2008, and 3 months later, I found a lump in my breast. 3 months later.
Thank you very much for sharing your story.
From a very small tumor to a very big tumor in 3 months. And because I'm a scientist, I was able to ask for a mammogram, et cetera, et cetera. So the average person doesn't have that scientific background and wouldn't know how to advocate for themselves.
Okay, excellent. Thank you very much for sharing your story and your expertise. Next, I would like to give the floor to MP Demoff. You have the floor for 6 minutes.
Thank you, Chair, and thank you to the witnesses for being here today. I've had the privilege of visiting Dr. Daniel's lab, and I hope, Dr. Caron, I'm hoping I can get out to yours in Prince George as well. But I just want to say that I would say that you two women are two of the leading experts in Canada, if not in the world, on breast cancer, on Indigenous and Black women, their experience with breast cancer. And I'm just wondering, did the task force consult with either of you in determining their guidelines? We'll start maybe with you, Dr. Daniel.
To be honest, I don't even remember. I was consulted on so many things over the past 2 years. I actually don't remember. I don't specifically remember being consulted. I know that I was on a panel with several people regarding breast cancer in general, but I cannot remember if it was the task.
That's okay. That's okay. And Dr. Caron, did they reach out to you at all?
I really appreciate you asking that. And no, they did not. They did not reach out to me. I'm not aware of my colleagues that work with me in this area that they reached out to either. And I just wanted to, acknowledge Dr. Daniel's personal story, the overlap in terms of the peoples in this country that are missing out. I think the task force really focuses on the majority, which makes the majority of people safe, content, feel represented, but it doesn't change the harm that's being done. I agree wholeheartedly. A social determinant of health is indeed racism. But I also want to point out what Dr. Daniel described and say that I think a social determinant of health is also access to research. The reason why screening mammography is firmly recommended at 40 or younger, really younger, for women with genetic abnormalities that actually increase their risk of breast cancer is because the research has been done to show that there's genetic abnormalities in those populations that put them at massive risk of breast cancer. I would say that when it comes to whether it's Dr. Daniel's population that she stands up so wholeheartedly for and is a voice for and is a cry in the woods. I think overall, I think we need to start to recognize that just because there is an absence of data does not mean there's an absence of risk. It means that there is a lot of work to do so that we can stop being what I used to refer to as the asterisk nation. For example, the triple negative data, absolutely. Absolutely. There was a well-known risk years and years and years ago with respect to African American populations in the United States, no data in Canada, and the massive increased risk in that population. Interestingly enough, when it came to the North American Indians, which was the terminology used in those studies, no data even available, could not even comment on it. And so the absence of data, the paucity of data, is not something to rest and go, whew, doesn't seem like there's an increased risk. I think it needs to be acknowledged, put forward, and said, what are we doing that we are basing guidelines when we don't even have adequate information upon which to place these guidelines on for these populations that the Canadian government is responsible for having heard?
Thank you. And I actually have a quick question for the chair. I know Dr. Daniel has a manuscript that she could submit as a brief, chair, and I'm wondering what the deadline is for briefs. And maybe while you look at that, I don't want to use all my time while you look. We talked about how the guidelines talk about people who are higher risk, and you both talked about how Black women and Indigenous women are at higher risk. And I think, Dr. Caron, you touched on this as well, but do they actually even have any idea that they're at higher risk? I mean, even white women who might have the XXX gene, how do you know unless you've been tested? Or maybe you've got a diligent family physician that follows the genetics of breast cancer. But I mean, to say that people who are higher risk can access at 40, is that a legitimate claim from the task force? I'll start with you, Dr. Daniel. I've got about a minute and a bit left. So
how do they know that they're at risk?
No, do they even know they're at risk? So would they even have any concept that they were at risk to go to their doctor and say, I'm high risk, I need a mammogram?
Olive Branch of Hope. This is what we've been doing now for about 8 years. We've been going to Black communities across Ontario and doing some virtual events in Nova Scotia and other places of Canada to basically just educate and inform Black women about triple negative breast cancer. And for the record, I would like to state that when I first applied for funding in Canada to study triple negative breast cancer in Black women, I believe that was in 2013, one reviewer, I didn't get funded. The reviewer said that my study of Black women with triple negative breast cancer was not relevant to the Canadian context. And receiving that as a Black researcher, a Black breast cancer survivor, and being told that studying a very aggressive breast cancer subtype in Black women in Canada was not relevant to the Canadian context was a serious affront to me and every single Black person in Canada, because that hurt to the core. Became part of our mission to ensure we educated every single Black woman about their risk. We have them fill out family history charts. To Dr. Caron's point, not everyone is aware of their family history. Again, there's a stigma. Many of us were told this person died from old age. In the Caribbean, people won't even say, oh, they had the C word. And so we have to be aware of these cultural differences and nuances. And again, that's why, as I said, the manuscript we're writing is called One Size Does Not Fit All.
Thank you very
we have
much.
To be aware of this.
Excellent. Thank you. At this point, MP LaRouche, you have the floor for 6 minutes.
Sorry, Chair, you'll give us the date for the briefs?
The Roosh, just 1 minute. The dates for the briefing has passed. It was October.
Oh,
Briefing documents with recommendations. If indeed you'd like to submit or have someone submit reference documents without recommendations, they can still be received. But the date was the October 21st.
thank you.
Floor for 6 minutes.
Merci beaucoup, Madame.
Thank you very much, Chair. I would like to thank our witnesses warmly for your contribution to this very important study. As well, during the study work, one of the activities that I conducted was to attend a very interesting breakfast conference organized by the Chamber of Commerce and which focuses on what happens when cancer strikes in a company. It was sponsored by the Quebec Society of Cancer with Miss Danielle Elkin, a businesswoman who was in attendance, and she was diagnosed with breast cancer. It was interesting what I was hearing here as I listened after the event beyond the taboos that have yet to be broken in companies for women to actually announce such a diagnosis is that I think all were unanimous in you all seem to agree on the importance of having an early diagnosis. I invite all of the witnesses to answer my question, but I've heard, however, there's a great deal of concern with this. That is, if you set the diagnosis at the screening at 40 and we are in a situation where we don't have enough resources, what do we do in order to ensure that at the end of the day we're not diluting this and that nobody will be penalized? So for you, yes, we are speaking about the diagnosis, rather screening at 40, but we have to ensure that we do have the resources available to respond to this diagnosis to make sure that nobody will be left behind due to a lack of resources. I think you also spoke about the important issue of access to care. So, Ms. Daniel, Ms. Shepherd, or Ms. Alitia, I invite all of the witnesses to answer my question. Thank you very much.
I'll go first if everyone's okay with that. In Ontario, we have expanded the Ontario breast screening program to women age 40. So we wouldn't do that unless we had the capacity to invite women age 40 and up to be screened. But in terms of the challenge, it's the follow-up. And many Indigenous women, especially those from remote communities in the Northwest, have difficulties with follow-up care. And some have even said no to follow-up care because it meant leaving their communities where they are the main provider of care and nurturing in the home. But I'm going to invite Amanda Shepherd to speak to that as well.
Thanks. I'll just.
Dr. Shepherd. Ms. Kiwa Yosh, next time you do have the floor, can you just be mindful to push your boom mic a little bit away from your mouth? Dr. Stewart, or Dr. Shepherd.
Thanks for that. I'll just add that there has been research in the Ontario context, and we do know that access to mammography is challenging. We know that fewer First Nations women who live on reserves receive mammograms, particularly in remote communities. So I think this is also a call for non-insured health benefits to ensure that there are funding. We're talking about access, that there's adequate funding for flights and supports to get women to mammograms. That point hasn't been raised yet, so I just wanted to mention that. And then also just to reiterate a point that Alethea shared earlier, that we do know that when First Nations women are diagnosed early, so stage 1, there's poor survival. So I think that's a real important call for early screening and close attention to follow-up care. Thanks.
Madam Chair, may I please speak to that question?
Yes.
I think it's a great question, and I think given time constraints to point out a few things, again, words mean a lot. There is a difference between access to screening mammography and utilization of screening mammography, and they actually come from very different cost expenditures and efforts and roles and responsibilities. In British Columbia, we are trying our best to address both, increasing access, not only in terms of geography, but also doing screening mammography with mobile units that go into rural, remote, Indigenous, and northern communities in the province. And that is greatly increasing access. Utilization means that a woman is aware of it, trusts it, and chooses to use that resource. And that means dealing with entities such as health literacy and cultural safety. I think when it comes to cost, it becomes very challenging, and it's above my pay grade to look at what a human life is worth. But we also have to remember that screening mammography not only detects cancer early, but it actually has a preventative aspect. Many of the patients that I see, when they have an abnormal mammogram, they are referred to a surgeon. I proceed to do the next steps, and often what it is something such as DCIS, or ductal carcinoma in situ, which actually is in situ and early before technically stage 1, and it can actually prevent invasive carcinoma from developing. Or it can even be more upstage, ADH, LDH, and otherwise LCIS. Bottom line is there are pathologic findings that you can find that are not invasive breast cancer, but change the risk profile of a woman so that she knows that she should get annual mammograms after that and do self-breast exams and do those annual physical checkups with her family physician to prevent breast cancer. And preventing breast cancer decreases the need for surgeries, chemotherapy, hormone therapy, radiation, and all of the healthcare required for the complications and the care. And finally, when it comes to this, women in their 40s, we have to remember these women are the women that are caring for their children and often caring for their parents. They are the crux of society. We must protect them. I hope I look like I'm in my 40s. I'm not. There is no self kind of benefit from this, apart from the fact that I do have people I love in my life that I want to protect. And I strongly, strongly think that it is worth a screening mammogram in their 40s and screening appropriate to risk of this common malignancy.
Very much. Leah, you have the floor for 6 minutes.
Thank you so much, Chair. I wanted to talk about, Dr. Daniel, you spoke about racism as a social determinant of health, and I know Dr. Caron, you spoke about impacts of colonization. I would say that for Indigenous populations, racism in the health care system is alive and well, and the mistreatment of Indigenous people in the healthcare system is quite pronounced, including a man, Jason Kennedy, who had the wrong leg amputated this month in the hospital. I think the real mistrust of the healthcare system is based on facts and based on experience. I wanted to start with you, Dr. Daniel. I wanted you to expand on how is racism, how does it become a social indicator of health in a current context?
So thank you for that question. So as I said, the American Association for Cancer Research, or AACR, is, I would say, one of the leading associations studying breast cancer for over 3 to 4 decades. Studying all cancers, for 3 to 4 decades. And a lot of the data that many of us in Canada and around the world, we use their data because they've been collecting ethnicity/race-based data since 1975, which is kind of bizarre considering what we think about many American culture. But as I said, in 2020, I believe they released their report saying that racism is now a social determinant of health. So they were looking at historical trauma, but also current trauma, such as racial profiling, whether it be when you go into the healthcare system, whether it be when you're driving your car, racial profiling in any scenario. They also look at the harm within the communities, environmental racism, such as having many of those communities, Black and or Indigenous, physically located in places where the biohazards, et cetera, as well as perhaps toxic dumps, et cetera, are placed near to these communities, so where they have very little access to healthcare, and then they're exposed to toxic chemicals. So
Profiling, would you say that racial profiling also occurs in the healthcare system?
definitely, it definitely does. So, for example, I recently met several young Black women who felt a lump. They were under the age of 30, and they were dismissed by 3 physicians who said they were too young, they can't have cancer, they're too young, and their concerns about the lump in their breast was dismissed. In one case, it was dismissed for almost 2 years. I also met a young Indigenous woman in 2018 where she first felt the lump at the age of 22, and she wasn't taken seriously until she was 24, and by that point it was advanced stage breast cancer, and she had to have a double mastectomy at the age of 24. And so this racism,
A double standard of care, like just looking at research between Black, Indigenous, and people of color and Caucasian?
I am not a physician. I can't speak to what goes on in the hospitals. I can only speak about the women or the men that have told me of their lived experiences. We're publishing a study on that as well. So there are definite differences between how they're treated by the healthcare system. And I think it depends on the region. I don't think it's the same in every single hospital or every single province, and we have to be aware of that. We're not saying that it's general. Dr. Karan is ready to respond to this, but we have to be aware that there is systemic barriers and racism that we are aware of and have experienced ourselves.
Move over to Dr. Shepherd, because you mentioned the First Nations Inuit Health Branch and providing equal access for Indigenous women to get mammograms. This is a critical issue, kind of 2-tiered healthcare in this country, one for Indigenous peoples and everyone else. How is a lack of access to healthcare placing Indigenous women more at risk for not being diagnosed at earlier stages of cancer?
Yeah, thanks for the question. I think the evidence is pretty clear, no matter who you are, that prognosis is better with an earlier detection. I did highlight how what we've seen in Ontario is poor survival even with the stage 1 diagnosis. So I think a sort of 2-pronged red flags, I guess, to really support early access for First Nations, Inuit, Métis, and urban Indigenous women. So I did refer to remote communities earlier, but urban Indigenous women are also having barriers to access mammography and other care. And just to add to the point earlier about racism in the healthcare system, with some qualitative work that we've done in the province of Ontario, repeatedly we saw comments about how women were being sort of pushed out of the healthcare clinic and being told to take Tylenol when they were expressing concerns of pain and fears of different health conditions. I'll let Alethea speak more to the issue.
Excellent. Unfortunately, MP Gazan's time. Our panel. On behalf of the committee, I'd like to thank all of our witnesses for being here, for sharing your testimony. Because we have separated it into 2 different panels, it's a little bit of a different structure than what we're familiar with. So thank you very much, witnesses, for being here to share your testimony.
Thank you.
Chi Miigwech, thank you for this opportunity.
Thank you.
Log off. Okay, before you log off, Just allow for one short question?
Yeah, not even a question to them.
Okay.
It's more for you, procedure-wise. Usually when we have two split rounds, like 2 rounds of panels, it goes, there's another round for the Conservatives and then another round for the Liberals. So usually it's an extra 5 minutes for each. And I don't know if the second panel is just one panel opening up with 5 minutes of comments.
Yeah.
And only one witness, because that might actually allow
No,
us to
I
go
welcome
quicker.
that, but the housekeeping, we have taken care of that. There was intention to get extra rounds by both parties, but the time is not on our side, and we have a full second hour. So unfortunately, that's where we're going to leave it. At this point, we will suspend for about 5 minutes to transition to our...
Point of order, sorry, just before they leave.
Sure.
I know earlier on, and I'm wondering if we have agreement of the committee to send, because this is the only panel that we
Thank you.
Indigenous and Black women, so that if they have anything else to add.
Yeah, the actual briefing deadline was October 21st, so it's a ways back. But what we are still willing to accept from the analyst perspective is all the documents with regards to reference documents. They are still more than welcome to be submitted.
Okay.
So,
Can I ask a question?
Chair, I would
Chair.
study to hear from more witnesses, and so the original deadline doesn't make sense, given that we
put a motion forward.
I
Consent around the room. We can extend the deadline.
okay.
Okay, so I don't think we need to go to a formal vote to extend the deadline for briefs. So if it's the wish of the room, we can extend that. What date do you find reasonable? Another couple days?
the analyst to see
Okay,
if maybe
so we'll,
Chair, could we give them to the end of the week? I mean, they just appeared Monday, and I think it's a little bit unfair. And so if we could give them until the end of the week, it's still a short timeline for these very busy people to put something together for us. But the other thing, on Emanuela's point, we started this meeting at 11:05 and we finished it at 11:55. I had wanted to have 2 hours with these witnesses, and it was cut back to 1 hour, unfortunately. But I really think we've cut them short. If anything, I would prefer to allow at least one more round of questions for them and extend the meeting by 5 minutes, because we've had less than an hour with these witnesses.
from a logistical standpoint, if we go further, we'll be going into far past an hour. We have a full second round. Trust me, it was my intention to have a full second round of all parties, and I recognize this is the first time they've been here, but we're going to move into the second hour. As there was a comment from the gallery, is that we've already spoke about this for 5 or 6 minutes, so we're already cutting into our second hour.
Well, but Chair, we only have one witness in the next hour, and there's 5 minutes of testimony from them. So I thought it was the Canadian breast cancer.
Housekeeping that we need to get through. So at this point, if there's no further questions, I'd like to suspend for about 5 minutes while we transition into our second panel.
May I please just request about the deadline?
Of this week. Thank you.
Okay, may I suggest something? One is what we're looking for, I'm guessing, is things that are not already available to the task force in the public space, published papers and that. The Indigenous way of sharing knowledge is it does need to be cleared. There is a lot of data that I think would help the task force. It is owned by the communities and it must be respected. And so I would need to check with the First Nations Health Authority to see what would be able to be released. That is vital data that has been ignored for decades. I cannot just submit it just because I was involved in the research. Individuals, First Nations individuals, based on OCAP principles, deserve to have at least their voice represented in terms of the First Nations Health Authority governance to okay it. And I don't know if they're going to be able to do it by Friday. And I really hope their voices aren't silenced by a deadline that's just put out without concepts being interpreted from the Indigenous perspective.
Thank you. MP Sidhu?
Thank you, Madam Chair. I just want to say that because that's why we invite the medical experts, and we should extend the deadlines so their voices can be in there, because we want good data too, right? So the second thing, my colleague Pam, there's no way we can extend just a little bit time just to maybe, we can ask some questions.
No, we need to move into our second panel.
Chair, I'd like to move a motion then. I'd like to invite these witnesses back then for another hour. I think we've shortchanged. These are the only experts we've heard throughout this study that have reflected Black and Indigenous perspective, and I hate to do that to them, to invite them to come back. The folks from the Ontario Health Authority, we didn't have very much time to even ask them questions, so I'd like to move that we invite these witnesses back for 1 hour on this study as soon as possible.
So at this point, is it the will of the committee? Okay. Well, looking at the schedule, we can make it happen for December 2nd. Mm-hmm.
Thank you, Chair.
Okay, at this point, we'll try again to suspend for 5 minutes while we transition into our second panel. Thank you very much again to the witnesses. I do apologize for cutting you short today, but logistical wise, it's just where we're at. Okay, so we'll suspend. Order. The committee will resume our meeting on the study of breast cancer screening for women aged 40. A few additional comments before we begin. For our new witnesses, I would like to acknowledge, please wait until I recognize you by name. And for those participating, of course, by video conference, please check on the microphone icon to activate your mic, and please mute yourself when you're not speaking. You may speak in the official language of your choice. Interpretation services are available. You can have the choice of floor, English, or French by using the interpretation function at the bottom of your screen. If interpretation is lost for any reason, please let me know immediately. At this point, I would like to welcome our second panel of witnesses from the Canadian Task Force on Preventative Health, both joining by video conference. We have Dr. Ghislaine Thierault, physician, and Dr. Donna Reynolds, physician. At this point, I'd like to open the floor. You have the floor. Whoever would like to go first, or if you'd like to split your time.
I'm going to address. So thank you, Madam Chair, and all members of Parliament present today for your invitation to engage with the Canadian Task Force regarding the 2024 draft recommendations on breast cancer screening for women, specifically today for women in their 40s. We look forward to any input from your committee as we work to finalize the guideline. I am Dr. Ghislaine Thierault. I have worked for the past 28 years as a family physician in Quebec's urban, rural, and remote areas, while teaching many generations of upcoming physicians. I am the chair of the task force as well as the chair of the Breast Cancer Screening Update Working Group. Besides my degree in medicine, I have a diploma in evidence-based healthcare from Oxford University. I am accompanied today by Dr. Donna Reynolds, a family physician colleague. Dr. Reynolds holds a specialty degree in public health and a master's of science in epidemiology, and is also involved in teaching as well as in research. She is the interim vice chair of the task force. We are both volunteers on the task force. For the past 8 years, we have been contributing our time to the mandate of developing preventive healthcare guidelines for primary care practitioners across Canada. I am aware that there have been previous sessions and witnesses on this important topic, and that the task force, its members, and the draft guideline have been the subject of some concerning statements. As it has been the case for previous meetings, I ask you, Madam Chair, to ensure a safe place for our discussions today.
Point of order, Chair. Point of order. I'm getting a time. I'm still hearing the translation right now in my headset. There's something wrong with the timing. I don't know if anybody else is getting that, but
Anyone else in the room having difficulty?
I'm still hearing stuff. I don't know if she's still talking.
No, at this point, it seems as though you're the only MP that's having issues. Do you want to try unplugging?
Okay. As it has been the case in previous meetings, like this is what I'm getting.
Ms. Thierault, if you could continue your testimony and see if it is getting better for MP Damoff.
Of course, Madam Chair. Breast cancer is an awful disease that touches too many lives. As physicians, we both have experienced the fear felt by our patients and their families. While tremendous improvement in the treatment of breast cancer over the past decades have resulted in significant reduction in mortality, we are very conscious that there is much more yet to be accomplished. We strongly believe we can do better for Canadian women. It is clear that many misunderstandings remain. The one I must mention now is the difference between screening and diagnosis. Individuals who have symptoms that could be breast cancer, such as a lump, need to be investigated. Even if this investigation includes a mammogram, this is not screening, and the task force guidelines do not apply here. I want to emphasize this. Anyone with a symptom should see a healthcare provider. The evidence about screening is complex, nuanced, and needs careful and transparent interpretation. That is why the task force undertook a comprehensive look at the evidence, including recent observational studies. From all of the evidence, we found that the decrease in breast cancer mortality from screening individuals 40 to 49 over a 10-year period is about 1 breast cancer death avoided for 1,000 women screened. This magnitude of a benefit was relatively consistent, whether we looked at older randomized clinical trials, recent observational studies, or the modeling exercise we commissioned. And what about the harms of screening in this age group? The evidence we gathered showed that screening results in 2 individuals being overdiagnosed with breast cancer, and 368, more than 1/3 of women screened, would require additional tests, including follow-up mammograms, ultrasound, and/or biopsies, to be told they do not have cancer. Some refer to these as false positives. Many primary care practitioners and patients are surprised by these numbers. To help us understand what this means to patients, we commissioned a comprehensive review of studies on patient values and preferences. What would they choose to do once informed about benefit and harms? The evidence showed that a majority of patients in their 40s weigh the harms as greater than the benefits. But we know from the evidence that there is variability. Some want to be screened while others do not. This is why our recommendation starts by stating that breast cancer screening is a personal choice. It specifically says that if someone is aware of the benefit and harms of screening and wants to be screened, they should have access to mammography. The task force recommendation, therefore, is about empowering women to make informed decisions about their health. There is no right or wrong decision. The right decision for the woman is the one that aligns with her personal values at that point in time. I now welcome your questions and comments.
Thank you. And does Dr. Reynolds also have any additional comments?
Madam Chair, we prepared for a 5-minute opening statement by the task force as a whole.
Point, I would like to welcome MP Vieng. You have the floor for 6 minutes.
Merci beaucoup, Madame la Présidente.
Thank you very much, Madam Chair.
You et Renaud.
Ms. Dr. Theriault and Ronald, we were very eager to hear you, and as a committee, we were eager to hear your viewpoints. I know that there will be many questions regarding the recommendations that you're preparing to submit. I sense, and I think rightly, what the room feels today. That is, the MPs are quite in agreement to go forward with early screening as of 40. And contrary to what you've told us, Dr. Theriault, is that you unanimously agree, but against that recommendation. So all individuals who have appeared before us here, all of the witnesses, all of the survivors, and those who've had horrific difficulties to overcome within the bureaucracy in order to obtain screening and to fight for these screening tests, all of those persons who appeared here, including the expert panel that we heard earlier that spoke to us, are all telling us that it has to be as of 40 years of age. I'm a former member of the Quebec Government Parliament, and at a certain point, it's easy to understand a situation in the balance of disadvantages between being anxious about having to undergo repeated testing and screening and diagnosis, even for cost reasons sometimes, and on the other hand, to possibly have a sense or of a clear picture of what will befall us, if only to reassure us. It seems to me that screening as of 40 years of age is the least of the things that we could do today. Especially this week, there were articles that appeared in newspapers saying that young people of 40 years of age are increasingly being diagnosed with cancer, but we had not previously been seen, not necessarily just breast cancer. But what are you telling us this morning? How can you convince us that your directive not to believe us at 40 years of age is the right thing to do, whereas everybody, including the provinces in Canada, and only Quebec has yet to go forward on that, are saying exactly the opposite of what you stated?
And members of parliament, this gives me an opportunity to talk about our methods. So the task force does a recommendation on different aspects of prevention and screening. And the way we approach, we look comprehensively at all the data. So we have looked at all data, old and new. All the observational newer studies are incorporated in our thinking about these recommendations. That is, a I don't know what to say more, that we did look at comprehensively at all the data, including data on values and preferences of patients. We had more than 86 studies informing values of preferences of patients on breast cancer screening. And it was clear.
Madame Thériault, j'ai peu de temps. Mais vous nous dites, je ne sais pas.
Dr. Thériault, I have very little time. You're saying that we no longer know exactly what to say. Well, explain to us why in the United States, the Canadian provinces, all of the persons who appeared here, all of the parliamentarians present here, and some of us have received diagnoses or know or have been through vasectomies. What is it that you're telling them today? You're not convincing anybody at this time. Nobody here is convinced.
Madam Chair, so I'm here not to convince anyone, but to explain our process and how we come by to make our recommendations. And this is through a rigorous process of looking at the evidence. So we looked, like I said, at all the different types of studies. We put all that together. We look at studies informing on values and preferences of patients, and we put that together. And the decision is made by the task force as a whole, not by one person, but the task force as a whole that can look comprehensively at all those data. What I say to a woman that was diagnosed in her 40s, and I have had patients diagnosed in their 40s, this is such an awful diagnosis to have. When I related in my opening statements the number, I told you that when we look at women 40-49, if we screen them for 10 years, out of 1,000, one will not die of breast cancer because she was screened. And maybe that was her. That's a possibility. Yes.
Merci. C'est parfait. Merci.
Thank you.
MP Emanuela, you have the floor for 6 minutes.
Thank you, Madam Chair. Thank you to both of our witnesses for being here today to answer some questions. I think I speak for Canadians when I say that the recommendations or the new guidelines were very disappointing for any woman or anyone who's at risk of getting breast cancer reading them. And so I have a couple of questions. My first one is, what efforts were made to ensure that the guidelines benefit all Canadians at risk of getting breast cancer equally? So you've spoken to looking at the evidence. Of course, the United States made a move based on their evidence. Why was their evidence or the evidence that they used not included? And from what we've heard, why aren't all Canadians or women living in Canada benefiting equally?
So, Madam Chair, I'll do my best to address the question. We looked, like I said, at every kind of evidence, so randomized trial, observational studies of all kinds, but we also commissioned a modeling exercise to inform our recommendation. We also looked at Canadian jurisdictional data. we incorporated statistics from Statistics Canada in our evidence review. We also add 1 month of opening for anybody that wanted to submit any document in the summer of 2023. We had a knowledge exchange in September 2023, and we did open for any further comments or documentation for a bit more than 2 months this summer in 2024. So I think all of this put together explains the way that we try to gather all perspective from any interest holders in Canada.
Thanks. So, women at increased risk because of family history are recommended to begin screening and doing genetic testing earlier. But we heard witnesses today who said that a lot of women don't have access to their family history. And a lot of women, specifically Indigenous women living in Canada, do not have access to this history very often, because of colonialism and because of the different disadvantages that they've had in the last decades. Was this taken into account, considered? What do we say to these women who don't have access to that and yet who are discovering that they have later stage cancer at an earlier age?
So, Madam Chair, this gives me the opportunity to clarify what the guideline is about. The guideline is not, like I said in my opening statement, about diagnosis, but it's about screening. So people that have no symptoms, that's first thing. The second thing, it's not about screening women at high risk. This is, if you read the guideline, you'll see. We incorporated women at average risk and women at moderately increased risk. And we define moderately increased risk as a woman having 1 first degree or 2 second degree diagnosed after age 50. Anything that's more than that or different than this is not considered moderately increased, but probably goes into the high risk screening, high risk strata, for which we don't have a recommendation because that was not our mandate.
I have another question. Why is women's enjoyment of a mammogram taken into account when mammograms save lives? Why was there a disclaimer saying that this is, the choice of the woman, making it seem like it's not really something that could help you prevent death? If you could just clarify that. I don't think that there's that kind of an asterisk when it comes to men's cancers. So I'm wondering if you can share why you thought that was necessary on these guidelines.
Madam Chair, again, so interesting that I can make some precision on this aspect. So for each of our guidelines on cancer screening, we look at the balance between benefit and harms. And one of the harms would be to have what's called a false positive that we renamed, additional testing showing no cancer. And the other arm is overdiagnosis. And in the 40s, when you look at the numbers that I just provided in my opening statement, and that you can be found very easily on our website on a 1,000 person diagram, if you screen 1,000 women, 40 to 49 for 10 years, you will avoid 1 death from breast cancer in those women, those 1,000 women. 368 will need to have additional testing, and 2 will be overdiagnosed. When we present those numbers to women, and when I say we, I'm not saying the task force, but the studies, more than 86 studies on choice about breast cancer screening, we found that women in their 40s may weigh the benefit, the harms greater than the benefit. But we did acknowledge that there are a lot of variabilities for that, and that some women may want to be screened and others may not want. And that's why we made the recommendation that we made.
If I may add, this is why for breast cancer screening, it's a personal choice. Women need to know what is purported the benefits. They need to know what are the harms, and they need to bring that into their values and preferences. So there's no right answer, wrong answer. Sorry, so there's no wrong answer. It is what's right for the women at that time. We have the benefit in family medicine is that we don't see someone just once. So if someone's changing their mind or if they have additional questions and want to come back, that's fantastic. It's a dialogue.
At this point, MP LaRoche, you have the floor for 6 minutes.
Merci beaucoup, Madame la Présidente.
Thank you, Madam Chair.
Je confirme que le comité.
I do confirm that the committee was very eager to put questions to you. But in the preceding panel, Dr. Caron said that there's a difference between the recommended service and available service, and that stayed with me since we are talking about the study today.
Une étude aussi.
So you're here, but there's also a study on women's health at the Status of Women's Committee. I was speaking about this with my committee member, Luc Thériault. I was also part of the study on women's health, and it is, in fact, in the report. That is, you do the issue of screening at 40 is being discussed. So we've heard a number of different witnesses who've also addressed this issue of screening at age 40. However, let me come back to this, however, because we have some questions for you that were put to us from survivors or from individuals living with cancer. My first question is this: who did you consult? Did you ensure that there was representation by women in terms of the cancer rates? Have you, that is, we spoke about the difference between Indigenous women and racialized women and women of African descent, so they have different backgrounds. Also, women with a certain family history. Did you glean that diversified viewpoint as part of your study? Madam Chair, this enables me to speak about the methods we use to incorporate the different viewpoints from a number of different patients. In terms of the task force on the updating of breast cancer screening, we had 3 patients. 2 had the lived experience of breast cancer. And I can tell you that in terms of diversity, that is ethnic diversity, there are differences that present in these patients. As well,
but we have a group also.
Vous n'avez pas à vous excuser de parler français, ça va?
You don't have to apologize for speaking French.
Is well understood by my colleague. So we also have a group called the TFPAN, so the Task Force Patient Advisory Network, that we consult at different moment in our guidelines. So they have there is a diversity of individuals on that task force panel. We have met with the Black Physicians of Canada to discuss our evidence synthesis, and we have also obtained data from Statistics Canada, and we are happy that it was published recently. A study was published very recently, so we can share the data as they were analyzed by our group. So, for example, if you look at Black women, we know that in the 40s, there is 1 more death per 1,000 person. So this is something we will surely incorporate in our upcoming tools and guideline. Dr. Reynolds, do you have anything to add on this?
Yes, I think this is the first time that we...
Dr. Reynolds, I do have another question, so if you could speak rather quickly, I'd appreciate it. Thank you so much.
Certainly. The new information that we received of cancer incidence and mortality by ethnicity, we had never had before, and we were able to see that within Canada. I think it's raised just such important questions, and we're hopeful that this committee will be able to influence research into that area because it is so important. In particular, does screening make a difference in these on these types of cancers, and we do not know that.
Écoutez, en passant, salutations aux interprètes qui font un travail exceptionnel.
Well, I'd like to thank our interpreters who are doing an exceptional job. So we do have the opportunity of speaking in the language of our choice to the committee. I'd like to congratulate the interpreters for their excellent work. However, what would you answer? Because I'm trying to ask a question about the representativity in terms of the persons you consulted as part of the work of the task force. So we've heard in the healthcare sector criticisms indicating that you did not receive sufficient expertise regarding women who are living with cancer. And perhaps you could confirm that as well. There is a criticism saying that some experts simply dismissed patients or other information, and some people tried to contact you to share their expertise with you, but please respond in 30 seconds. I know we have very little time, but and I just want you to confirm that their studies were dismissed. Thank you very much. I'll respond in French. As I explained, there was a cultural diversity, both in terms of the patients involved and others. But in terms of expertise, we had 4 experts that assisted us from the beginning to the end of our report: an oncologist, an epidemiologist. We had 2 oncologists, epidemiologist, and a generalist. So in the summer of 2023, we had a month available for all persons who wish to share information with us, studies, or all types of other information. We also had a knowledge exchange in September 2023. After that, we had 2 months where we were receiving comments, references, anything that could improve on our conclusions and recommendations.
The floor for 6 minutes.
Thank you, Chair. How did you pick your research subjects? Let's start. How many people were part of the research study? How many subjects? Just a number.
So, Madam Chair, I'm unsure of what the question is exactly, but how did we pick the topic? This is an ongoing process, and Dr. Reynolds can speak to that.
Study.
It is an open...
Sorry, I don't have a lot of time. The people who were involved in the study, how did you pick them?
So we don't do studies, we do systematic review of studies. So we did 3 systematic review of studies.
Right, but how many subjects were based on that review? What was the population sample?
You mean the population sample of the studies? That's what you mean?
Yeah.
Yeah. So like you already know, and we know, the majority of the women in the studies that we looked at were of white ethnicity, and this is something we have said.
Okay, thank you. So 98% of the subjects that you based your research on were Caucasian. And I say that because you spoke today about values and preferences. We know that there's higher rates of cancer diagnosis or younger diagnosis for Black, Hispanic, Asian, and Indigenous women. In the U.S., in fact, they recommended early screening at 40. Some researchers have recommended, in fact, 25 for Black women. How was your study in terms of making a recommendation for screening? How did it take into consideration more at-risk populations?
So thank you for this question, Madam Chair, members of Parliament. So we did look at statistics from Statistics Canada that were provided to us and are now published, so you can access them. So you can find in this report of Canadian statistics is that actually most women that are non-white have a lower incidence of breast cancer in Canada. Some have the same, so there's no statistical difference, but most of them have a lower incidence. The ones we see that have a higher incidence are Filipina and Arab women. So Black don't have a higher incidence.
Oh,
They have a higher incidence of-
can I pose a question here? Part of the issue is access to screening. We've heard from several witnesses that many, for example, Indigenous folks don't go to get screening or health care due to colonization, but ongoing systemic racism within the healthcare system. Did your study take that into account when it made the observation that Indigenous women, Black women, have lower rates of cancer based on those kind of historical factors? Was that part of your research? Yes or no?
Yeah, well, just we use research to inform recommendations.
Did that
research
then inform your recommendations? Did that
Yes,
research?
It did.
It did.
The research was just published by Dr. Wilkinson, which you heard about, and it showed that there is a lower incidence of cancer in most racial ethnic group, except for Filipina, Arab, and and women that identify themselves as multi.
Yeah, but did that research inform your recommendation to have a screening age of 50? Yes or no?
If I may.
This information prior to their publication, and it did when.
Yes.
Because
yes, it.
For example, it noted that Black, Hispanic, and Asian women breast cancer peaks at an earlier age of 40 when compared to white women. Recent Canadian analysis shows that Caucasian women are the only group whose peak incidence is greater than 40. That was by Dr. McCurley. Is her information inaccurate? Because it's conflicting with what you're sharing here today.
Yes, well, I could share the data. I mean, you have to, sorry about that, Madam Chair, I'm sorry. So we have read the study, and what we find is that the median age at breast cancer diagnosis for Black is 56 compared to 63 for white women.
She goes on to say that the task force was aware of this recent yet to be published paper from Statistics Canada in terms of this research, but did not lower the screening age. So you were aware of this research for Black, Indigenous, Hispanic, and Asian women. So what was your reason, being aware of the research, not to lower the screening age? Because you were aware of it.
So, Madam Chair, I will try to just repeat it, and maybe Dr. Reynolds can do a better job at this, but we were aware of this information, and like I said, most racial groups in Canada have either no significant difference in incidence of breast cancer than white, or a lower incidence, except for women that identify as multi-ethnic, Filipina, and Arab, but this does not translate in increased mortality. What we know about increased mortality is that Black women in their 40s, there is 1 per 1,000 women. Instead, I will ensure, and we'll all ensure the task force, that this information is even more prominent in our documentation. It's already there.
Thank
but
you.
We're going to make sure it's even more prominent in our documentation.
Thank you. We would like to begin second round. Anna, you have the floor for 5 minutes.
Thank you, Madam Chair. And I'm getting a little concerned about some of the comments that we've heard here, but I do want to recognize Carolyn Holland in the room, who's a survivor. So I'm going to ask my first question is, do experts vote on the guidelines? And if they do, why not?
Dr. Reynolds, you want to take this?
Certainly. The task force follows international accepted standards for our methods. And when we're looking at experts in their roles, the recommendations is to have them as non-voting members. And the reason for that is that what they see and how they see is very different. They see people with disease as opposed to family physicians, primary care. We see the entire population. So specialists or experts, they tend to recommend interventions at a much higher and more frequently than independent panels. And the evidence definitely supports that. As a result, is our experts are not, there are non-voting members as per standard guideline best practices.
Say that, you know, Carolyn was diagnosed at the age of 40, I believe, and she's here today because of the early diagnosis. We heard earlier from a witness, Dr. Daniel, who said a Black and Indigenous community struggle with getting diagnosis, but there was an Indigenous woman who was diagnosed, who found a lump at age 22, was put off, was told, go home and take some T3, it's just pain. At age 24, she went back, and sure enough, it was breast cancer. So here's my question. I come from the financial background, and if someone came to me for a mortgage because I was an expert in that field, I would be better equipped to diagnose and understand what their needs are. So when I go to my family doctor, I just had recently knee surgery, she had to, you know, direct me to a specialist. Why are we not having specialists on this task force who understand that women's lives are vital and important to the community?
Through you, Madam Chair, thank you. The task force, as you know, provides recommendations for a broad array of topics, breast cancer being one of them. In guideline development, it is recommended that those who the guideline is directed at for us as primary care be the constituents of that panel. The experts have a perspective that differs from primary care. Theirs is completely valid in their realm of practice, and our perspectives are also equally valid in our practice.
Our witnesses earlier, we had testimony that the Canadian Task Force argues that screening at 40 causes unnecessary stress that comes with callbacks. However, life-threatening ulterior diagnosis that affects your physical, mental, and emotional health, and while it was stressful waiting for the results from the biopsy, it would be even more stressful and downright dangerous to delay screening and a possible diagnosis. I'm sorry to disagree with you both, but I think women's lives are important, and I think that we need to revamp this task force to ensure that we have individuals on the task force that understand that I'm not, you know, I'm a woman and I can handle it. I can handle that news. I don't mind being called back if it means that I'm going to be alive to tell my children and grandchildren that I survived breast cancer. So I'm not trying to put you guys down. I don't know where you're getting your research, but all the evidence that points to witnesses that we've had that breast cancer must be diagnosed early in order to save lives. And if it's history in the family of breast cancer, why are we waiting?
So if I may, go ahead, Dr. Theriault.
To answer this? Yes. Okay. So like I said, we're both clinicians. We have dealt with numbers of cases of different kinds of cancer. So we feel this, the message we put forward is that breast cancer screening is a personal decision, and it is based on values and preferences. There are benefits, and like I will say, out of 1,000 women, 49 screened for a decade, one will avoid breast cancer death because of that. But there are also additional testing showing no cancer and overdiagnosed.
Thank you very much. Unfortunately, I have to cut you off there. Thank you very much. Next, I'd like to welcome MP Hepner. You have the floor for 5 minutes.
Thank you, Chair, and thank you, doctors, for being here to answer our questions today. I know you've been under some intense scrutiny as part of your role with this task force. I was also going to ask about the lack of subject matter expertise on the panel, because we heard that from a lot of witnesses who came from us here, but you didn't have any experts in radiology or oncology or other areas of breast cancer on the panel specifically. You've sort of answered that partially. If you have more to add, please do. But in particular, I spoke with one radiologist who specializes in breast cancer. She said she had an opportunity to review the findings of the panel, but if she did so, she was going to have to add her name to the document, and then she'd not be able to take her name off the document if she disagreed with the findings. So she said subject matter experts were staying away from consulting with the task force because they couldn't have a say on whether they agreed with your findings or not. What's your response to that?
So, Madam Chair, there's a lot to answer to this, but I already explained we had 4 experts on the working group from the beginning to the end: oncologist, radiologist, and breast surgeon. You can find on our website all the comments that are made on our systematic review and the answers we make to that. So there's not many groups that do that, that are transparent like this and put forward publicly all that we received and all the answers we give to these comments. So we will continue to be transparent. For the other part of the question, I don't know, Dr. Reynolds, if you want to comment.
So I think transparency is so important. We want to have clinical experts, subject matter experts, to be able to provide their input, but they also have to be transparent about it. So putting their name, and we say it does not mean that they agree with the recommendations, but we have to be transparent that they provided input into it. Otherwise, we would be hiding something, and we're not that. We're a transparent organization. So, these are principles of good guideline development and is consistent with our best practice methods.
I also spoke with a group of experts in cervical cancer, and I believe there are screening guidelines coming up for them. Are you the same group? And will you change any of your task force or any of your methodology given the history with breast cancer when it comes to cervical cancer?
So, Madam Chair, the task force does recommendations on different screenings. So yes, cervical cancer screening is one of the topic. It is ongoing. We have experts involved in the process, and we, like we do all the time, send all of our documents, like the protocols, the systematic review, the guideline, to interest holders. So all of these people can participate, give comments, and we will answer these comments and make that public. Yes.
Okay, thank you. Dr. Theriault, I think one of the reasons why this issue got so heated early on, before you even came out with the recommendations, is because you were getting into social media fights with survivors and other experts. How is that helpful?
You could read all my posts. I don't know how to answer that, Madam Chair. I'm sorry I didn't address you first. You can read all my posts. I don't think I got into any fights, but I would have put forward little things. Like, for example, they would say that breast cancer screening in the 40s would reduce breast cancer death by 50%. But I would put forward that, well, this is what we depicted, from 2 out of 1,000 to 1 out of 1,000. That's 50% less. So this is the extent to which I intervened, is to give some factual data that is easier to understand.
Okay, thank you. And when you talk about breast cancer screening being a personal choice for women, do you think that's taking into account the barriers that many women face? For example, not having a family doctor, not having access to your family history, not necessarily knowing or being grown up with the notion that you have to check yourself.
So, Madam Chair, this gives me the opportunity to talk about all that we're planning to do to ensure that our recommendations can be implemented and reach as many women as possible. So we have the guideline, we have the 1,000 person tool that can foster a discussion with the primary care provider. We had in the past a real shared decision making tool that we're looking into doing. We are looking into videos, doing videos, and also doing an interactive tool online for women so they can access the information in absolute numbers in a transparent way that do apply to them and be empowered to make a decision that aligns with their values and preferences.
Thank you. Adrienne, you have the floor for 2.5 minutes.
Merci, Madame la Présidente. Écoutez, est-ce que vous avez reçu la lettre du comité, mesdames? Donc, vous avez bien reçu la lettre en juillet du comité de la condition féminine avec 4 observations. Recommandation 1. Donc, le groupe d'études devrait abaisser l'âge recommandé dans les lignes directrices canadiennes pour le dépistage du cancer du sein chez les personnes présentant un risque moins.
Point of order, Chair. I'm not getting translation. I'm not getting any translation, Chair.
Pause your time for a minute, Adrienne. And continuez en français. Is there any translation happening? Okay, is anyone else having the situation? I think Dr. Reynolds, I see you're not getting any translation either. Okay. So we'll just suspend for a quick minute while we work out the translation.
Tenter de résumer. Donc, observation 1, le groupe d'études devrait abaisser l'âge recommandé dans les lignes directrices canadiennes pour le dépistage du cancer du sein.
Not getting any translation.
We en français, you're not understanding nothing? It's coming across in French? Okay. Right? Are there
In English. Can you hear me? Can you hear now?
Testing the interpreter now. Can you hear the interpretation now? Well, are we doing a test?
Can you hear?
I'm checking, and I find it very interesting when I come to my question. Suddenly, I cannot finish my question.
Can you hear one of us?
Je parle pas si vite, mais je vais continuer.
I don't speak that quickly, but
Okay,
I
I
am
won't
going to
speak too
continue.
fast. Can you hear me?
Very well. Madam Chair,
Madam Chair,
I'm wasting
losing
time, and it's going
right
to
now,
be
and I'm really sorry. I'm
difficult
going to be
for me to
penalized
continue because I
don't
don't
know where
quite
I
know
am
exactly
anymore.
where I
Can I
started
have
off.
my
May I
2.5
resume my
minutes
2.5
back?
minutes?
Yes, of
Very
course.
well.
La lettre que nous vous avons fait parvenir au Comité permanent de la condition féminine.
I wanted to know if you
letter that we
received the letter
sent
that we
in
sent to
July
you.
with 4 observations. The first one, the study group should lower the recommended age for this breast cancer screening for those who have medium risk to include 40 to 49 years of age to reflect the advice of experts. The task group should take into account of all testimonies received during the meetings of June 11th, 2024, and include a complete examination of everything that has been included, which is
qu'elle s'appuie sur les commentaires pertinents du public, les recherches et les données probantes les plus récentes et qu'elle reflète la technologie médicale moderne et les progrès au chapitre des traitements. Observation 3. Le groupe d'études devrait veiller à ce que le processus de consultation publique sur le cancer du sein, mise à jour, donc recommandation provisoire 2024, soit transparent et que les résultats de ce processus soient rendus publics.
And we will look into accountability. And the last observation number 4, is that the task force should look at these recommendations, for these temporary recommendations 2024, to make sure that women who have dense breasts get a extra screening with MRI. What do you have to say about these 4 recommendations that we have made? Madam Chair, thank you very much. I can tell you very quickly that we have answered this letter extensively, and you will find more detailed responses that I can tell you in the short time allocated right now. So we have the most recent data, and our systematic review goes back to the summer of 2023. So all recent observations within the large study that you have had are included in here. Yes, you have answered, but we have to understand that what we have been hearing since we started this study again does not seem to be what was recommended by the expert witnesses that we heard, which is why we had this letter sent last June. And I consider that your response does not take into account everything that we have heard since.
I don't know if I should say anything to this. Is that a question?
At this point, I'll pass the floor to MP Kazan. You have the floor for 2.5 minutes.
Thank you so much, Chair. I just want to go back to what I was talking about in terms of sample, because I know you based it on other research and you didn't take, but all research is based on samples. So I'm going to read another quote by Dr. McCurley. She added that not only, and this was in the letter we sent, were the studies that were prioritized during the development of the draft recommendations out of date, but they also used a sample population comprised of 98% white women, which means that you would have known. I would assume if you're looking at research, you would want to know what the sample of your research was. I want to go back to something you said about only that that out of what you found with Black, Indigenous women, that only Filipina women had higher rates. How can you base or how can you state that finding when only 2% of the data collected were non-Caucasian women? I ask that because don't you agree with me that's too small of a sample size to base an overall recommendation for screening?
Okay, Madam Chair. So there's two questions in there. So that we prioritize studies that were out of date. We had a comprehensive review. We looked at studies that were old, but also very recent observational data.
I'm asking about the sample. Were you aware that 98% of the sample you were looking at in the research and data collected were 98% Caucasian women?
So, Madam Chair, I think I answered that question before, but just about the Filipina. So just making sure that we understand us well today. The Filipina data that I gave, it was not just Filipina, but Arab, Filipina, and multi-ethnic. It's not from the study.
How much of the sample, sorry, I don't have a lot of time. There seems to be, I mean, all the expert witnesses that have come here have indicated that 98% of your sample size was Caucasian women. That means that 2% were other in the data collected, the sample on which you based your recommendation.
Dr. Theriault, maybe I could take this. So the studies.
This is very troubling because you spoke about the recommendations trying to, or you were trying to reflect the values and preferences of your subjects, yet you don't know the sample? Is that what I'm hearing?
What you're hearing is that there's not evidence for those people. And this is what we're trying to get across, is we need the research into this area.
In your recommendations, it did not take into account then Black, Indigenous, and people of color.
So I would respectfully, Madam Chair, just say, just go and look at our tools. It is mentioned. We have a mention of the Black, the increased death in Black women. It is mentioned. It's all there.
What we know is there.
At this point, Layla, you have the floor for 5 minutes.
Thank you, Madam Chair, and I want to thank you guys for taking the time to come here. I think it's pretty clear at this point that Canadians don't trust what you've put out. Canadian women shouldn't trust what you've put out. In fact, most provinces have decided that your guidelines aren't worthwhile, and they have changed their guidelines on their own. The biggest comparison to our country, the United States, they've lowered it to 40. You've completely ignored anything that they might have decided as to why they've done that. And here you've been continually trying to say that the harms from breast cancer screening outweigh some women living. I think this is incredibly concerning. And effectively, the harms that you've been able to describe to us at this committee are anxiety. And frankly, women can handle anxiety. I've had to live most of my life, in fact, my entire adult life, without my mom. Because my mom got breast cancer and died at 49 years old, before cancer screening would have allowed her to potentially catch that. She might be here today had she not found her cancer before it was at stage 4 and virtually every option was closed to her. She lived 11 months after she was diagnosed with stage 4 breast cancer. So I will not accept that anxiety and false positives are somehow the same as women dying. Just based on rough math, one person will die. That means 400 additional deaths. So your study is saying it's okay because only 400 women will die. I don't know if anyone around this table is okay with an extra 400 women dying because stress and anxiety is too much. What do you have to say to these women and the families of these women that are having to now live with that?
So, Madam Chair, I will start an answer and Dr. Reynolds will continue. our recommendation doesn't say that harms outweigh the benefit or benefit outweigh the harms. Our recommendation says that women can be and should be empowered to have the information about the benefit and harms to take the decision that aligns with their values. Dr. Reynolds, you want to?
Your data also says that you don't think women between age 40 and 50 should get screening because you've decided that the benefits don't outweigh the harms, and therefore this is the conversation we're having around this table. We've had the same conversation around the health committee table. We're now having it at the status of women committee table, and we're wondering how we've had witness after witness come in here. Experts say that this is not working, and yet you are standing with this. The health minister went to extraordinary lengths and even wrote saying that he was disappointed with your findings, and you're standing here coming to our committee saying that this is all okay and you stand by your findings. How do you stand by your findings?
So, Madam Chair, our role is to look at the evidence and to put all the evidence together to come up with a recommendation. That's our first role. And that's what we have done.
We very clearly heard that the evidence is sorely lacking. Women's health does not get the appropriate amount of research compared to other types of health. And so, of course, there might not be enough evidence. When the United States has decided that it's worth lowering the cancer screening down to 40, when most provinces have decided that it's worth it, why are you so intent on standing by clearly flawed evidence rather than women's lives are worth it?
Dr. Theriault, maybe I can step in. So these recommendations are conditional. They're conditional on the values and preference of individuals. So we are not saying don't, everyone, do not. We are saying not systematically screening 40 to 49. We are saying inform women about the benefits and harms and let them decide.
That women under 50 shouldn't get screened, which means people like my mom die. That's
that is not
eligible to get a mammogram until she found a lump because she was under 50. My mom has been dead for nearly 15 years. That's the reality. That is what we're dealing with right now.
So I hear your pain. It's obvious, and I hear your pain at this moment. If you read,
it's beyond pain. It is beyond pain, and you are not taking into account anything to do with the women that have had to go through additional chemo, radiation, surgery, all of the rest of it. You are not taking into account any of the additional harms that come with later stage diagnosis. So I'm sorry. I'm not just angry about my mom. I'm angry about every single woman whose lives are impacted because this screening guideline is failed. This is flawed. I'm angry because there are families that have lost loved ones because you refuse to accept that your evidence is flawed and perhaps your answer needs to change. And you came to this committee and you continued down that path and you've doubled down. And you know what? Everyone around this room does not like what you've said, and we do not agree with what you've said.
Thank you. Sonia, you have the floor for 5 minutes.
Thank you, Madam Chair. This committee has heard from the doctors. I would say that we heard from Jean Seeley and Anna Wilson, and screening women from age 40 would have saved our health system over $400 million every year. And it is big amount, big burden on healthcare system. Did the task force consider these saving in its analysis of the benefits of the screening?
Madam Chair, thank you for this question. So the methods of the task force is really to look at the benefit and harms about individual person. We have a section on our implementation and cost effectiveness that we do look at, but it's not the basis on which we make our recommendations.
Dr. Reynolds, several witnesses have told us that your task force ignored and dismissed input from experts. One of them, Jenny Dale, said that experts were excluded from voting on the guidelines and that the task force publicly cast doubt on those experts' integrity. What do you have to say about this?
So, through Madam Chair, I think it came to me, Dr. Terrio, and I will be pleased to pass any additional questions or issues to you. So we included experts on the working group. We included experts, a radiologist, we include a radiation oncologist, a medical oncologist, and a breast surgeon on the working group from start to finish. They were intimately involved with the guideline from along with our patient partners throughout the process. So the idea that we did not include experts in our in this guideline is false. Plain and simple, is false.
And we heard repeatedly in this committee about breast density as a risk factor of cancer. Yet the task force gives women with a high breast density the same recommendation when it comes to screening as women at low risk in their age bracket. Why didn't the task force highlight the difference in the benefit of screening?
Madam Chair, so referring to our tools, you could see that we did highlight the potential higher benefit for women at dense breast. It is on our tool. We said 1.9 death averted instead of 1, based on one study of higher risk. The other thing is we looked if we should screen women with dense breast differently. So we looked for studies that say, should we add ultrasound or MRI? And as the U.S. has found in May 2023, there is no such study to inform patient-oriented outcomes.
And Dr. Terrio, from the first panel, we heard from Dr. Karen earlier today, the residential school system disconnected many Indigenous women from their family history. This makes it impossible for them to get the normal risk assessment for breast cancer. Doesn't this constitute a barrier to access to screening for Indigenous women? And my colleague raised this issue, 98% and 2% in data. So I just want to answer for that, how it, you counting on that.
Unfortunate for all those women that don't have this information. The answer is not easy because they might be at high risk and this is not covered by our guideline. They might be at moderately increased risk. So we have the numbers to inform those women, but if they don't know, I realize it's very difficult. I understand that. Regarding the 2%, 98%, we did include the most recent observational studies. So this has changed. I don't have the numbers by heart, but I could surely transmit them to the committee if you want about the most recent observational studies. And that's why we asked Statistics Canada to provide any information they had about breast cancer and the diverse ethnicities in Canada.
And if I may quickly add to that, is about the dissemination of information. It is not just the task force. We've learned that some provinces are now looking at how to provide the information on benefits and harms so that women can be informed. There are multiple cancer agencies that we look to as well who have wonderful communications ability to be able to get these messages out so women can be informed and decide for themselves.
Thank you, MP Sidhu. Just from the position of chair, I would like to pose one question. It's more or less just a yes or no. And is there any consideration to change or edit or revisit any of your guidelines?
So Madam Chair, reviewing every guidelines every year with a quick overview. Maybe I'll let Dr. Reynolds, because she knows more about that.
Yes, always. And look forward to the public comment, all the other sources that were coming in to make sure that it's meaningful.
That does conclude our second panel. On behalf of the committee, I would certainly like to thank both of you for your presence here today and providing some answers to some questions. So thank you. You can excuse yourself. I really appreciate you guys coming today. Lastly, for members in the room, I did mention that we had some housekeeping things. I know we're tight for time because it is already quarter after. A couple things. Drafting instructions for breast cancer was intended to be this coming Wednesday. That's now going to be bumped until December the 4th to allow for the extra meeting on December 2nd. Okay. In addition to that, we have an informal meeting request from a delegation of women parliamentarians from the Ukrainian parliament that was shared by the clerk on November 7th. The delegation is visiting in Ottawa. Sorry, they are visiting Ottawa, and they've asked to meet with us for an hour in the afternoon of Wednesday, November 27th. They have a jam schedule that day, but they have a window of time available, 1 hour, that fits during our committee meeting. So does the committee agree to have the delegation come from 4:30 to 5:30? Okay. So in addition to that, so that's a yes for that. And the new study on violence targeting the 2S LGBTQI plus community was slated to begin on November 27th. But now we're accommodating the Ukrainian delegation, and we've added the breast cancer study. So we will be starting that a week later than we had intended on. Is that fine? Okay. In addition to that, does the committee agree that the committee defray the hospitality expenses that are related to the informal meeting? So we can just go from one to the other, okay? Lastly, thank you for that. Lastly, since the study of violence targeting the 2S LGBTQI plus community is beginning a little bit later, we're going to have to extend the briefs on that. And we learned earlier that we want to ensure that we have enough time for the briefs. So can we delay the briefs to Wednesday, December the 11th? Deadline currently was December 2nd. Okay, so we're just bumping things back. We will send an updated schedule to everyone just because I know there's been some changes, but I wanted to make sure that we were certainly agreeable with the delegation coming, because that was the malleable piece that was going to be changing things. Okay, awesome. Motion to, MP Damov?
You said the Ukrainian delegation was November 27th from 4:30 to 5:30. So is that meeting only going to be 1 hour?
Second hour with, I'll have to check and see what's on the schedule, but there will be a full 2-hour meeting, but the 1 hour of it will be with the delegation.
Okay, because you had said that day we were supposed to start the 2S LGBTQ2 plus study and we couldn't. So I'm just wondering what we've got planned for the other hour.
Breast cancer study, so. New study on the 27th. We could do. I will circle back with you, MP Damoff, and the other MPs. Whether it's the breast cancer study or additional witnesses from the other. So there's there's some changes just because of what's happened here today, but I can confirm with everyone.
Okay. Okay, thank you.
Motion to adjourn.